Dr. Mike Ingui, and we are going to now talk about all of our clinical aspects of focal shockwave, and even maybe, again, bring in that comparison to radial pulse versus focal shockwave.
Absolutely.
So let's start spinal. We're chiropractors.
Sure.
Let's start with spinal. If you had to pick conditions within, let's go low back first, since it's probably one of the greatest causes of lost work days in our country is low back. Mm-hmm. What is the thing that you most want to treat?
Yeah, discogenic pain.
Okay.
Honestly, even degenerative discogenic pain, which most patients that are experiencing this disabling pain, that's honestly, it's a very common cause.
Now,
it works great.
Are you, again, using that in, you bringing in McKenzie with that? Are you bringing in
Absolutely.
your other decompressors?
Yeah, listen, I think it's important to know, right? Listen, I'm not going to stand here and say that, listen, this machine is a cure-all. No, it's not, right? Like you said, we're chiropractors. Yeah. The power of the adjustment, the manipulation, it's extremely important. But, like anything, technology advances. The human body advances. This tool is going to significantly enhance everything that we're doing. This brings it to the next level. Yeah, absolutely, I'm going to do McKenzie. I'm going to do directional preference. But is directional preference going to actually help the annular fibers heal? Probably not, right? So utilizing this technology in addition to your directional preference, in addition to, let's say, your McGill core stabilization exercises, it's going to get that person not only better, faster, but reduce the risk of re-injury. And I think a lot of people lose that sight. I said, great, you can go, I can get better in a week. Well, that's great. Well, what great is it if you get better in a week, but you have 4, 5, 6 episodes a year that knocks you out for 2 or 3 days? That's not acceptable. Right? My favorite, I'm sure you've had this. I've had the back pain patient that'll come in, every so often and be like, "Oh, doc, I've been doing great." I said, "I threw my back out again." I'm like, "How many times are you throwing your back out?" Maybe 4 or 5 times a year. And I look at them and I said, "That's not normal." All right? That's not normal to have a debilitating episode where you have to call out of work and you're in an antalgic position for multiple days on end 4 or 5 times a year. That's not normal, right? And I think we need to really start with, why? Are there limitations in our treatment? Because I think a lot of doctors can feel that patient that I just explained. I think a lot of us have those patients in that practice, right? Well, how do we take those patients and reduce those episodes, maybe to once a year, or hopefully resolve it, right? And I feel that this technology has certainly, helped us, significantly. And I've had those cases where I've used on, patients with discogenic pain, and sometimes it works really, really well. Where, I remember one particular case, the guy works in an old printing press, like a mechanic, and he still actually utilizes a printing press. And he would come into me every 3 or 4 months, would have to call out from work, and I would see his name pop on the schedule, and I said, I know exactly what the problem is. Let me get the table ready. Let me get everything ready, and we utilize this device on him. And I actually called him about a month ago. I said, "Hey, what's going on, man? I haven't actually seen you in 6 months. It's around, it's around Christmas. Just want to see how you and the family are doing." He's like, "We're doing great." So just that, that alone, I've noticed that it's helped, with that particular patient.
I'm going to throw something out, and I'm not sure if you even have the answer for this.
Sure.
Have they ever done pre and post MRIs on a disc to see healing? Now, because I'll add to that for a second.
Great
because
question.
One of the things that always drives me crazy is when I have like a 75-year-old patient that comes in and they have their MRI and they're like, "Well, I have a disc herniation." I was like, No, you don't. You're 75.
Exactly.
You didn't herniate a disc at 75. The disc from 55 forward starts becoming fibrous.
Exactly.
It's no longer jelly center anymore.
Exactly.
What you have is an old disc herniation, probably from when you were younger, that's still never going to heal and shows up on your MRI. That's why I throw the questions here.
No, that's a great question, and I'll be honest with you, I haven't really dug necessarily in, in how deep that research is. And again, I think to your point, would it necessarily change, the way, we're doing things?
Absolutely
and
not.
I don't think so,
It
right?
doesn't.
So I'm glad you even mentioned that, because that's exactly it. Same thing with rotator cuff issues, right? A lot of patients, 50 and over are going to have some degree of a rotator cuff tear. I have multi-level disc, herniations, and guess what? I still power lift, and I still practice, and I have no issues. So I think I'm actually glad you referred that, because I think there's a lot of, patients coming in with MRIs, and, obviously this goes above and beyond with Shockwave. Listen, certainly imaging is important, but patients are getting this, and, then all of a sudden they start catastrophizing. And, one of the things I've seen, again, not to certainly downplay the Focus Shockwave, it's sometimes a little bit of a struggle because, patients look at this. I have multi-level disc herniations, and it looks really bad, and they have a tough time believing that this little IBM-looking computer from 1978 is going to do everything that we said, right? People are, they want to go into the big surgical center. We have the big fluoroscopy machines, and we're going to do these injections and these big procedures. Well, you don't necessarily need to do that, but I think it's important to note that, listen, this technology, it's like a procedure. It is a procedure. So I never downplay it, right? I always tell patients, I say, listen, yes, it looks kind of, looks old school, but, let me tell you, you're going to have to do the same thing you would do if you were going to get an injection. You're going to have to do your pre and post rehabilitative exercises. There may be some soreness. We may have to do some slight activity modification. Certainly much less activity modification than if you were to have a injection, certainly if you were to have surgery. But, people really do need to understand that, yes, this is a procedure. There's really very little downtime. There's very little activity modification. But people need to also understand that, no, all right, I still have to take it seriously because, yes, this thing isn't just some fancy gizmo that's going to, it feels like an ultrasound. I can assure you, it is much, much different than your typical therapeutic ultrasound.
Look, if you're going to get the procedure done and go squat 450 pounds with a rounded back all the time, you're going to damage the back again.
Yes.
All right, so obviously, and unfortunately, I do think in society nowadays, people don't want to change their lives. They don't want to take accountability. They don't want to do that extra.
Sure.
And I do think you saying that is critically important to understand, look, it's not the light switch. We don't just get to turn it on and off,
right,
and you'll be cured. Will it get you better faster?
Absolutely.
Yes. Could it save you highly expensive and completely debilitating procedures?
Absolutely.
Yes. But you still have to understand that you have a responsibility to yourself to keep it healthy and to maintain it. Now, I want to talk about that for just a brief second before we go on to another condition.
For sure.
You had mentioned to this when we went to your office. We noticed people come back once a month, once every 6 weeks, just to get the procedure done again because they're maintaining their health.
Yeah, that's a great question. So typically with Focus, we'll do a treatment protocol and anywhere from 4 to 8 visits, right? And let's take a knee osteoarthritis condition. I would say in our office, probably knee OA is one of the most common actually conditions we treat. So after the initial protocol, about 4 to 8 sessions over the course of 4 to 6 weeks, we actually let the patient, it sits there. Now, they'll still come in and we'll do their, chiropractic work, we'll do their physical therapy work, we'll continue to do their strength loading exercises and everything else that's necessary. But the magic of Shockwave actually starts to happen after the 90-day period.
Yeah,
right?
That was amazing to me when you told me
after
that.
the 90-day period. So you're going to, in that first initial 4 to 6 week period, we're stimulating these cells, and then guess what? It's just like concrete. You pour concrete down, right? Yes, within a month, it's going to obviously, within 48 hours, it's going to harden. But concrete doesn't really fully cure until months after you've actually laid it. Now, that doesn't mean you can certainly drive on it and whatnot, but the full concrete itself doesn't actually cure to its level of stiffness until months after it's poured. It's the same thing here. We've stimulated everything. You're going to actually start to get that cell turnover. Listen, again, like we talked about, you're talking new blood vessel growth, you're talking, protein and lipid release into a tissue. Like you said, it doesn't happen overnight. This takes time, right? But what people actually realize is they start to feel better a month or 2 months or 3 months after they finish the protocol. And like anything, typically at the 6 month to 12 month mark, sometimes patients will, basically come in for 1 or 2 sessions to basically have that effect again. Very similar to Symvisc that they're using now for the knees. I think they're also using it to some degree for the hips. It's the same thing, right? Where Medicare, you always hear Medicare will pay for this injection every 6 months, right? Well, again, that's because the Symvisc, let me tell you, it's great technology. And I actually have patients that do the Symvisc injections with the Shockwave, because the combination therapy, and again, I think that's so important because we live in a society where so many people, especially in medicine, and it either has to be A or B.
Yeah.
You know,
This or that.
it's okay to be A and B. So when I have patients that say, should I continue to get the Symvisc injections? I say, do you feel that it's working? They say, yes. I said, absolutely, right? This is only going to enhance it. Now, maybe you only need to get the Symvisc injections once a year. That's something that, you know, myself, you, and your orthopedist, everyone will discuss. But 100%, there's excellent research that shows that focused Shockwave with PRP or Symvisc has a much even desired effect. So I think that's really important, that people need to understand, you know, what's that expectation look like. And, you know, it really is, you really are looking at anywhere from like 4 to 8 sessions at weekly, sometimes twice a week intervals. So it's definitely, in the beginning, when you are actually doing the procedure, you know, I always make sure patients understand, like, listen, are you going away for like 2 or 3 weeks? Because once we start, we have to go through the protocol, right?
Yeah,
I understand things happen. Of course,
Yeah.
things happen here and there. We can extend it maybe 10 days out, but what we can't certainly do is do a session or two and then take a
Disappear
month
for 3
break.
weeks, yeah.
You know?
Now, with the disc, and then I want to move on to a different condition, because
absolutely.
I want. There's so many body parts that we can talk
Yeah,
about.
100%.
How soon will you do it? Somebody blew out their disc, literally Monday. It's Tuesday. It's Monday. Are you doing it on Monday?
Yeah.
Okay.
Absolutely.
Now, what are you seeing from the inflammatory aspect? Now,
Yeah, that's a
I'll say this all
great
the
question.
time, and I know when a few of us rewrote the scope of practice in New Jersey, going back a few years, we wanted to try and get, again, with proper education, get us limited prescription rights.
Sure.
Like the ability to use a Medrol dose pack or something like that.
Absolutely.
Because quite frankly, if a chiropractor is telling you you need to be on an anti-inflammatory, most likely you need to be on an anti-inflammatory.
Exactly.
And of course that got shot down. We were shooting for the stars. It wasn't going to happen.
Sure.
But I'd be the first person to say, get a Medrol dose pack and let me do McKenzie, some distraction, some decompression techniques with you, and I'm going to get you better a lot quicker on a disc herniation. Talk to me how you incorporate that aspect.
Yeah, I think
into
that's
it
a great question.
And how soon?
And listen, obviously it's always patient dependent, but truth of the matter is, you're talking a very small focused area. So I'm not going to, it's not like I'm going to be taking a device and inducing energy into an area this big, right? You're talking at this big, right? So if I'm able to stimulate angiogenesis, if I'm able to stimulate, you know, blood vessel formation, and more importantly, increase circulation, yeah, it's going to induce a small local area of inflammation. But I think a lot of people are missing the mark is, you're talking it's increasing circulation.
Yeah,
we're going to help improve lymphatic.
We don't heal without inflammation.
You know, so exactly, right? So it has to be controlled. Now listen, obviously, you know, it has to be case by case dependent. If someone's crawling into the office and antalgic, you know, listen, we'll try. You know, I mean, there's some tests you could certainly do, and a lot of it's clinical judgment, right? But for the average person that, you know, definitely has, you know, that traditional lateralization of pain, yeah, it works really, really, really well. And again, it's not that we're going to start on the max energy flux. We're going to start very, very small at a lower frequency. We always like to say we're going to start low and slow, right? In addition to some of our other therapies, and then as everything starts to calm down, we'll increase the energy, we'll increase the frequency to really start to have that desired effect.
I'm thrilled to have somebody with your experience, because one of the things that I know patients are usually terrified about is, I just hurt myself. Take 2 weeks. Oh, for the love of God, do not
Do not do
take 2
that.
weeks.
There's enough research,
It's
I think,
the worst
doing
thing in
that.
the world
So,
to do for
yes,
that.
yes.
So I think that becomes one of the more important things of making sure that people understand, like, I can get this done. I got hurt and it's severe. I can get it done immediately. I do not have to wait to find out it's okay to get it done.
Absolutely. You know, and I'm glad you actually said that, because yes, you know, we're spinal experts, it's a disc, but what about the ankle sprain case? We're utilizing this immediately on an ankle sprain.
Let's take an ankle.
So it's the same exact concept, right? We are trying to increase circulation. We want to stimulate those exosomes. We want to stimulate VEGF. I want to get stem cell healing ASAP, right? Because we all know what happens within that first 72 hours. You're going to start getting that fibroblastic proliferation. You're going to start getting that scar tissue formation. And that's the last thing you want to do. Like you said, these people that'll wait 2 weeks, after 2 weeks, that scar tissue's formed. I think and I always use the example, like I always throw that word, that cicatrix formation. A lot of patients are like, well, what? I said, I start doing this with my fingers, and they're like, I said, exactly, right? Think about your fascia. It's just kind of all bundled up like this, and it doesn't really stretch. It doesn't move. That's why you're stiff. And I think a lot of people definitely can relate to that, right? No, listen, obviously, I certainly in the beginning, I was a little bit nervous, but as I started reading more research and I've attended more seminars and certification programs, these orthopedic surgeons and pain management physicians in Europe are using this for things that I honestly, it's unbelievable. I mean, certainly extending beyond the use of, orthopedic applications. They're using it in neurological applications. I mean, I think one day, hopefully this country will get with the program, because Alzheimer's and depression over in Europe, they're actually utilizing a focused shockwave in the brain with some pretty darn good results. But, obviously, from an orthopedic standpoint, it's probably one of the best investments we've made in our practice, and a lot of patients have benefited of it. They've been able to, it's not just athletes, right? Because I think a lot of people, well, I'm not an athlete. I said, well, sure you are. Everyone's an athlete.
Just in a different phase.
Just in a different phase,
Yep.
Exactly, right? You wake up every day, you go to work, yeah, you're an athlete, right? You have to get up, you have to move your body to some extent, you're an athlete.
Phil Santiago said to me in my first sports med class, everybody's an athlete, just in a different phase.
Sure.
He's like, have you ever run before? Have you ever skipped before? Have you ever jumped before? If you have, doesn't matter when you did it, but you were an athlete at some point in your life.
Exactly.
Now, going from disc and ankle. Now, obviously, you already talked about ankle sprain. Mm-hmm. What are other areas? Like, Achilles. I'm going to throw them out.
Let's do this. So I think this is honestly really good, because I think also too, obviously every medical device in the United States has to be FDA cleared. Mm-hmm. Now, there's a big difference between FDA clearance and FDA approval. Yeah. FDA approval requires a robust literature set, robust literary review, and approval from the FDA. The STORS unit is actually FDA approved. It's FDA cleared to treat pretty much everything, but it's FDA approved to treat plantar fasciitis, Achilles tendonitis, and calcific shoulder tendonitis. So those are three major conditions that, quite frankly, can be very, very debilitating. I know STORS is working on getting FDA approval for other things, such as meniscal issues, knee osteoarthritis, hip osteoarthritis. But I think those three conditions alone are significantly debilitating for anybody that's ever had them. But let's keep going up the chain.
I have to go in with me now, just because you said meniscus.
Absolutely.
So again, everybody in my office unfortunately knows about this, because I have a loud voice and everybody hears me anyway. And when I'm limping around, that also doesn't look too normal in the office either.
Sure.
As a 53-year-old guy who can literally get on the soccer pitch and run around with almost anybody still, so long as they're not too good. The reality is I tore my meniscus at the end of October.
Sure.
And I knew it right away. I've torn my meniscus twice here. I've been able to get this one better. In fact, one was a bucket handle tear that I actually unlocked myself, which was really painful and uncomfortable. Didn't lock anymore. But this one was painful clicking. I mean, and it was pretty significant. Every single time it catch me, it almost like my knee would buckle on me. Those of you who had meniscal tears before, you understand exactly what I'm talking about. I was getting it worked on. My knee was so swollen, I even have pictures of this.
Sure.
It was probably out to here. By the time I saw you, my swelling had come down pretty significantly, but the painful clicking was still severe, still very uncomfortable. I've only had one treatment. Mm-hmm. I have absolutely no internal pain in my knee anymore.
Sure.
It literally disappeared in one visit. Now, again, I hate the one-time thing, which isn't reality.
Right.
But I'm still pretty fit, I'm still pretty athletic, and I'm not saying I don't have any discomfort. I still have some guarding muscles, some hamstring stuff that's going on, but the internal pain is gone.
No, exactly, and you'll be able to do that probably for your case, probably another 2 or 3 more treatments.
Yeah.
And over the next, probably several weeks, and you're going to notice, like I said, a significant benefit again over the next 90 to 120 days.
Like legitimately, I can sit in a squat now, which I couldn't go down a step before. Forget about up and down. I couldn't even do that. Yeah. And now I can literally sit in a deep squat. Like,
no, it's unbelievable.
As they say, ass to grass. I can literally get all the way down there now. Mm-hmm. It's kind of shocking, and honestly, as we were going through the process, which is of course why we were in your office, after that, I was signing papers.
Yep.
As soon as I saw what it could do for an acute meniscal tear, I was like, this is insane.
That was the same issue with my labrum. Same exact issue. And again, I think, for both of us, people may say, all right, what's the big deal? It's our livelihood. I said, I don't think people realize, we need our joints.
Yeah.
I said, you're talking, I make a living doing this. So, I was not downplaying, maybe my friends or even the orthopedist, they're like, hey, you'll be fine. I said, no, you don't understand.
This is my job.
This is my job. I make a living on this. This needs to be fully functional. And I think a lot of people can relate to that. How certain these orthopedic conditions can be debilitating to various degrees.
And you said with that, like the debilitating, of course, me being a chiropractor, especially a soft tissue specialist, what are the things that go on you the most?
Oh, absolutely, thumbs.
So I said right in your office,
trigger finger, fantastic.
How do you feel on the thumbs with this stuff? And you were like,
abductor and adductor pollicis, it works really well. I actually had a case. This was a young lady, and she's a graphic designer. She's actually an artist, and she makes a living on doing drawings and illustrations. And she had significant carpal tunnel for years. Actually had ejections and PRP. She had a carpal tunnel release, and kind of worked, but not really. She was still having a lot of difficulty gripping the pen, and we actually did we actually used a dynamometer, and I would say she was probably about 50% weaker in her dominant hand that she drew. It's a big problem. So we did 4 sessions over the course of a week, and we continued with some of her other strength training, her eccentric loading, and some of her other myofascial issues, and then we kind of retested it at month 3. Her right hand was actually about 10 pounds stronger than the left. And this was an individual that for 3 years was struggling. And, and again, I don't want to get into, I'm not really an emotional guy, but she was in tears. And, I think for me that was a great success because, again, like you hear this, and I was always a skeptical person. I think to some degree I still am, right?
I'm a cynic out the wazoo.
I'm a cynic out the wazoo. And, for me, and I finally just said, Mike, you know what? Remember how it was life-changing? Like you literally, it saved your ass. We just saved her. And I said, you know what? We can finally rest assured that. And again, I was. You look at research. You look at what the parameters were. So it's not like you're just taking this thing and you're going on a wing and a prayer.
Yeah.
No. We're utilizing protocols that have been well versed, that have been well studied. Right? For me, listen, I'm like you said, I'm not listening to the sales rep. I'm listening to some of the most world-renowned experts that I've had the privilege when I've attended these seminar trainings, these certification programs. I've had the privilege of learning from the best of the best. And you know what? These guys doing it, backed by robust academic papers. You're talking clinical trials, randomized double-blinded clinical trials. It's not just, like you said, a case study or case report. You're talking studies that have done hundreds and hundreds and hundreds, some of them thousands of people. And I'm sold.
So I came to your office, honestly, with complete nothing but cynicism in my heart.
Oh, good.
I was expecting.
I respect
I was expecting my meniscus tear to have absolutely no benefit whatsoever.
I respect it. I respect it.
That's why because using yourself as an example, you're going like, yeah, well, it's you. You could.
Exactly.
No, I actually expected not to do anything.
Same.
All right, we only have a couple minutes left.
Sure.
So I'm gonna do a little speed thing with you.
Absolutely.
And I want a thumbs up, a thumbs down, or we pass on it.
You got it.
Rotator cuff tears.
Oh, easily.
All right. Frozen shoulder.
Oh, fantastic.
Capsulitis, I'm assuming, would be the same thing.
Fantastic.
Then. People don't make the differentiation, but it's pretty huge.
Absolutely.
Elbow tendinopathies.
Good. I would say I would give it like a 4. Definitely good.
Okay. Carpal tunnel syndrome.
Fantastic.
See, that one I love hearing.
Fantastic.
Now, you've already talked about OA knee.
Fantastic.
Okay. What about something like labral tears in the hip?
Haven't done it enough. I know for hip osteoarthritis, fantastic. I personally haven't had enough research myself for hip labral tears.
Okay. TMJ.
Funny you asked that. Yes, I'm actually learning a little bit about it now because I do have a case. The radial is actually utilized really well, but I have read a lot of research where they are using focus for TMJ.
Okay.
I would still say the verdict's still out on that.
We've already got meniscal tear. I'm not even going to listen to you. I'm going to go. I already know it's a thumbs up on that one. Patellar tendon tears or chronic tendinopathy.
Yeah, I think fantastic. Certainly your grade 1s and grade 2s.
Because that's a frustrating tendinopathy for a lot of people.
Absolutely.
Anything that I've missed that you would say, hey, you totally forgot about this one?
Yeah, no, absolutely. Trigger points. Deep myofascial trigger points are absolutely fantastic.
What about deputrins?
Very good.
See, that's interesting because there is a conversation
about
all the time about
there is some
non-surgical
documented evidence on that.
But they always say non-surgical, but they say go contact somebody. They never say what the potential
right.
are.
Exactly.
So that's why I wanted to throw that one out there.
You're absolutely right. We've certainly talked about the disc. I think you pretty much hit the hit the major areas.
Well, the trigger points are interesting too because that, again, mainly because we're geeks, but understanding that those are literally deep fascial
Some of them are
adhesions.
very deep fascial adhesions.
So
Exactly.
even though you might feel the knot right here, the depth of it is pretty significant. So you're going to have to use something deep penetrating. I've said this. You heard it when I taught classes when you were a
When I
student.
was a student, absolutely.
The only thing we know we touch is the skin.
Exactly.
It's the only thing we know we get on.
Exactly.
We say, oh yeah, we're on the piriformis. You know how deep the piriformis is? You're not getting to it.
You're not getting
it's not
to it.
happening.
Exactly.
Last time you saw a piriformis was anatomy class.
Exactly.
But it's
Exactly.
interesting that we now have these technologies that allow us to get to tissues. Hamstring,
Are you talking, and same with bursitis?
insertional, yeah.
Right, you're talking chronic bursitis. It works. I think the moral of the story is, this technology certainly is a game changer. It allows us to deliver a much more therapeutic, effective treatment in addition to everything we're doing to treat a wider plethora of conditions. And I'm not saying that it's going to save everybody from going to an orthopedist, but it's certainly going to reduce the number of patients that are going to need more invasive procedures, more costly procedures. And you know what? I think really we need to learn that, it's not always about money. It's about time. Your time is worth something. So for me, if it means the difference of, I can get better in a month and go on my vacation, or I'm going to be miserable on my vacation, that's worth that. I don't care what the hell the price is. So I think, honestly, that's what we've been, and that's honestly one of the biggest reasons why we made this investment. And we haven't looked back. We are constantly every 6 months going to certification programs, going to seminars. I think it's so important because there's more evolving research on this year after year after year, and it's a field that is blowing up. And I think it's important to note, we'll end with this, it's not just chiros utilizing this technology, right? Medical doctors, physical therapists, podiatrists have been using it long before us as chiropractors. Like you said, not only are we 10 years behind in the United States, I think chiropractors, sometimes I feel like we're 40 years behind in leg treatments. I think this technology certainly brings us up to the level of quote unquote mainstream medicine and gives us, honestly, I think our fiduciary responsibility as doctors, quite frankly, giving our patients the best of the best, what's out there, does this actually work? I think that's the responsibility we have to our patients, is making sure, are we investing in the right technology, are we investing in the right education to be delivering the best possible results to honestly get you, the patient, whatever it is you want to get, right? Because everyone's goals are different. They're not my goals, they're your goals. And that's kind of where we always go with our patients. And, you bet, I bust my ass to make sure that I do whatever I can to make sure that my patients achieve those goals.
Well, first of all, thank you so much for coming.
My pleasure, absolutely.
We were, of course, missing Dr. Doyle today, and unfortunately, I think you feel the reason was pretty simple. Between him talking and me talking, there wasn't a room for a third person to talk. So Dr. Doyle will be back with us, of course, on our next podcast. But from two robust talkers with deep voices, Dr. Greg Dorr from Bergen Chiropractic and Sports Rehabilitation Center, Dr. Mike Ingui, thank you so much for coming.
Our pleasure.
His contact information will also be on there. He has offices in multiple locations, so you'll be able to actually look him up. If, God forbid, you're not in our catchment area, you will surely be in one of his catchment areas as well. Thank you for listening. Hope you got a lot of information for it, and we will start our focal treatments probably early in 2026. Looking forward to seeing you then.
Awesome.